Welcome and thanks for pressing play. This episode of War Docs was made possible by a partnership with the Defense Strategies Institute's OpMed TV and was recorded at the 2024 Operational Medicine Symposium in San Antonio. These interviews focus on optimizing military medicine through the modernization and implementation of policies, education, training, research, and development. We also explore emerging technologies to enhance the health, strength, and survivability of warfighters. Welcome to the special edition of War Docs in partnership with OpMed TV. I'm your host, Dr. Doug Soderdahl, retired Army urologist, and I'm joined today by Navy Captain Travis Polk. He's a trauma surgeon, and he's currently the director of the Combat Casualty Care Research Program with the MRDC?
MRDC, Medical Research and Development Command.
MRDC. It keeps on changing the name, but I think we got it right. Thanks for joining us today.
Yeah, absolutely. Glad to be here.
So tell us about this position. You're the director at this Combat Casualty Research. What kind of research are you doing?
Yeah, so we don't actually do research within our program. We're the funding sponsor. Our program manages DoD's science and technology investment in trauma. And so we have a very broad portfolio that ranges from everything from traumatic brain injury to tactical combat casualty care, immediate life-saving interventions, non-compressible hemorrhage, development of new blood products and understanding how better to use blood products, forward surgical care, prolonged care, critical care, organ support, wounds, en route care. We have an investment looking at autonomous solutions. How do we use new and emerging technologies in order to increase capability and capacity? So AI, machine learning, augmented reality, micro-robotics. How do we integrate all of those things to create autonomous systems that can allow us to do our job better? So it's a very broad portfolio, but essentially DoD is one of the principal, or is the principal funder of trauma-related research for the United States government.
Just so people can get a scope of this, how much money are we talking about in this portfolio?
Yeah, so it fluctuates from year to year, but about $130 to $150 million a year, sometimes more, depending on the congressional appropriation.
And how does your team prioritize what projects get funded? Is there certain things that are the hot button topics that we want to fund?
Right. So first, as opposed to how NIH funds things, which is investigator driven, DoD research is requirements driven. So everything we do is based upon a requirement for something that the DoD needs in order to execute its mission. So at the base of everything, we have requirements documents that guide us. And then we receive input from the larger ecosystem. So we receive input from the joint staff, from the joint trauma system, from the services on what their priorities are. And that helps us to adjudicate, in this, very large space, what do we need to work on? And it has to be a balance of what do we need right now or in the near term, and what do we need 20 years from now, because of the time that it takes to develop some of these complicated technologies, or the time that it takes medical pharmaceuticals or devices to get through a regulatory process.
So where would you say for operational medicine, where are the big research needs? Where is the operational medicine community saying these are requirements that are just not being met with what we currently have. We need some research done to help us.
It really depends on the area, but certainly blood products are always have been, always will be a need. We're continually striving to develop better blood products, increase the cold chain or eliminate the cold chain. That's a priority. It's a priority of the Assistant Secretary of Defense for Health Affairs. It's a priority of all the services. So we have a significant investment in that area. Along with that, we also look at what things can make that resuscitation better. So we invest in things like what we call anti-shock drugs, but things that may allow us to extend that window of opportunity between when people are injured and when they get to that first damage control intervention. And so if we can help mitigate that irreversible shock state with drugs in the future, in addition to the blood and other interventions, then we can give people more time, because we know that the battlefield is going to be complex in the future. We know from what we're seeing in Ukraine, it's much harder to move casualties. And so as there's more casualties, and we have periods of denial on the battlefield where we're unable to move casualties, we need to maximize the opportunity to try and lengthen that resuscitation period. That being said, we can't change human physiology, right? And so that's an important area of our investment. We're also looking at how can we use autonomy or to improve the way we do things, right? To give people more capability or capacity, or upskill the people that are in the field to deal with this complex problem of many casualties, of difficulty moving through the continuum of care. You know, we talk a lot about prolonged care, and prolonged care is an issue at the point of injury, but it's also an issue everywhere within the battle space. And so the more we can provide, the answer isn't always technology, but there are technologies that in the future will allow us to take care of more people, to make decisions faster, to understand the overall situation faster, and that in the long run will save lives. You know, the other area where there's a lot of interest and we have to develop capabilities is in terms of returning people to duty, and particularly returning people to duty in theater. Whereas we've had the luxury within the last 20 years of conflict to easily evacuate people home, in the future we may not have that capability. And for those with less severe injuries that can recover within several weeks, we need to optimize the therapeutics that we have to get to heal their wounds faster, to improve their functional recovery so that they can get back to the fight.
Yeah, I mean, I think that's one of the things in my deployments that I really noticed was that really once you evacuated someone out of the theater, it was very difficult to get them back in easily back to the unit. But if you could have some way that they could recover whatever they had quicker and not have to leave, I think that would be a great adjunct to kind of keeping the readiness there, right, and not moving it out.
So within our area, we also manage the Armed Forces Institute of Regenerative Medicine initiative, and so within that, we're looking at wound solutions that can help heal wounds faster, heal minor burns, and then for those that do have significant injuries, increase their ultimate functional recovery.
So what would you say are some of the kind of the cool or major wins over the past several years? I mean, this program's been around for a while.
Right.
What are some of the fruit that's come out of it?
Yeah, so certainly blood products, we're now using cold stored platelets on the battlefield, and they're becoming increasing in use throughout the civilian world as well. The use of whole blood has been a return to the past, right? And so we've learned more and more about whole blood, its utility, and now it's our primary, resuscitation fluid. Hemostatic dressings, tourniquets, all of those are significant accomplishments, that have come out of the last conflict and research that we've done within the last conflict. So TBI, was one of the signature injuries of our last conflict. When exposed to blast, many service members have significant mild TBI or concussion, but then some have more significant TBI, and sometimes it's hard to discriminate between those, and it becomes an evacuation challenge. The gold standard is to get a CT. Well, CT is not available everywhere within the battle space, and to move people just to get that becomes challenging. So blood-based biomarkers, so through work done at the Walter Reed Institute of Research initially, and then moving into the FDA approval of the Banyan biomarkers, which then led to the more recent FDA approval of Abbott's blood-based biomarkers for GFAP and UCHL1. Now we have a tool that we can use in real time to determine whether or not someone has a potentially more significant head injury and help us make decisions. Along with that, there's many other diagnostics that are coming out related to TBI that can help us determine whether there's bleeding and an occupying space lesion. And those together are going to give us a significant capability in the future with regards to TBI. And so, I think that's one of the greatest success stories of, that have come out of these lines of effort over the last several years. But, there's many, right? So, at any given time, we have hundreds of different projects at varying stages. Some of it is very high risk, high reward, early research. And some of it is, later stage advanced prototyping or moving towards FDA clearance. And then we do clinical studies as well. We have a robust clinical study network for trauma that we have on contract. And so what's unique about that is we have a network of over 40 trauma centers and pre-hospital systems that's under contract with the DoD to execute clinical studies. And so we give them what our priority is, and then they develop a study and do a multi-center trauma study.
And you guys don't get involved in the regulatory stuff for that. You just say, this is an IRB approved thing, and you fund it.
So only in the fact that there are requirements that they have to meet. Particularly, many of these studies are exception for informed consent studies, which have to be approved through the Surgeon General of the Army's office prior to starting. And it's because of that they're being done prior to consent being able to be obtained in an emergency. There's a higher bar for approving those. But we've been very successful, and the study has now, within 8 years, has begun work or completed 6 exception from informed consent trauma studies, which is really remarkable.
Yeah.
So that's separate from the materials that we're developing. We also do knowledge product work, and so learning better techniques, understanding how we use therapeutics better. And so not all of our work is about developing a new gadget or a new thing or a new drug. A lot of it is about understanding better how do we deliver trauma care in the military environment so that we can inform the JTS clinical practice guidelines or tactical combat casualty care or the civilian community's trauma practices.
So it impacts the policy and doctrine.
Absolutely.
Yeah. So one of the other things that I know that you have an interest in is medical simulation for training. Tell me where you think we are at our current status for training, all the way from the medics and corpsmen to neurosurgeons or trauma surgeons. How well do we do in simulation to train?
DoD has invested quite a bit over the years in developing simulators for medical training and specifically for military medical training. And I think we now have many fantastic trainers that are able to be used in exercises, in various schoolhouses. Simulation is a fantastic tool, and the key with simulation is we really have to look at what we're trying to accomplish with that. The same simulator may not be the best tool for doing individual skills practice or training with a surgeon or a medic, as opposed to doing team training. And so, as I've worked at a few different simulation centers and run different training programs, what becomes really important is that we understand what we're trying to accomplish, because the simulation space is large.
Right.
It may be synthetic simulators that may be the best tool. Cadaver-based training may be the best simulation tool. have courses like the asset course for our surgeons, where we go over vascular exposures. We also have things when I was in LA County at the Navy Trauma Training Center, we did a lot of work with perfused cadavers, which are an excellent tool that kind of meshes that individual training for the surgeon with the team dynamic and the team training in different scenarios. And then there's of course live tissue training. Then also, is the virtual space, right? Or the mixed reality space. Right. And so depending on what the objective is, if the objective is more knowledge or basic psychomotor skills, there may be trainers that are best for that. If the objective is team training and team integration, there may be different tools that may be most useful for that. I think where there's the greatest opportunity in the future, so certainly I think there's huge opportunities in the mixed reality space, both for training as well as assisting in the provision of care, right, using tools like augmented reality. Where on the training side, I think where things still lag but eventually we'll get there is in terms of haptics, right? So it's still, if you're going to cognitively go through something, then those are fantastic, tools. But at least in the virtual space, we don't have high enough fidelity haptics yet to really make that realistic training. And so
how far away do you think we are?
I think we're still pretty far away. Do I think eventually we'll get there? Probably. We'll get there for a lot of different reasons. And training will probably benefit from it. Mm-hmm. I think with some of these technologies in this kind of continuum of virtual reality to augmented reality to mixed reality, I think the training side will be the benefactor of some of the other use cases for them. And I think they'll be, over time they're going to be developed for other use cases. Right. And then, we'll be able to benefit from the training side. But I don't necessarily think that on the training side, we should be pushing that, because I don't think, in prioritizing the investment, we won't be able to meet that, requirement. The industry and other use cases will be the driver for that.
So you mentioned the Trauma Training Center that you were involved in Los Angeles, and mm-hmm. that is a kind of a military-civilian partnership, LA County, USC Med. Tell us a little bit about that opportunity and why it's important.
Yeah, so for 3 years I was lucky enough to run the program in LA County, and that program's been around for over 20 years. It was one of the first military-civilian partnerships that was established. And initially it was established to help train our Marine Corps forward resuscitative surgical suite teams. Over time it's morphed a bit, but the primary mission of that center is still to train surgical teams before they deploy. And so we had a core group of cadre of faculty that were assigned to that center that worked, part-time in the trauma center, and then part-time conducting the training for our teams that rotated through. And it was a fantastic synergy between the two.
Now, how do the teams rotate? Do they rotate in right before they're getting deployed, or how does that work?
Yeah, so it really depended on the platform. The way we deployed in the last conflict, so many of our units were constituted right before deployment.
Right.
It created, it further created the need for this just-in-time training. And so, so a lot of our teams would rotate through, within the few months before they deployed. But then other teams that were, like our fleet surgical teams that support our amphibious ships, they would rotate through as just part of their training schedule. So it really just depended on the platform and what their needs were.
So your experience, you deployed on a ship, and you've also deployed in Afghanistan, taking care of ground troops, Marine special operators. How do you prepare for those differently, and what is the similarities and what's the difference?
Right. So my shipboard time was 20 20 years ago, right after I graduated internship as a general medical officer, and I don't know how we prepare anyone for that, right? But it was a fantastic opportunity. So I was on a ship that we ferried Marines around, and so we were based out of Japan, and we would take Marines all over the Pacific. Great opportunity, very different environment. Was useful for my future Navy career in understanding, how ships function and how the Marine Corps functions. Whereas, my deployments in Afghanistan, were very different. My first deployment was with the Role 2. My second 2 deployments were as the Chief of Trauma at our Role 3 in Kandahar. Preparing someone for a Role 2 deployment is hard because you're relatively isolated. The reason you exist is to do the most emergent life-saving surgeries. And so that's a hard thing to prepare folks for, particularly because a lot of the surgeons that go to do that, aren't trauma surgeons, right? They're general surgeons, and they all do trauma in their training.
Right.
But then they may have specialized, and they may be,
Right.
they may be an endocrine surgeon or something else. And so, how do we maintain that core trauma competency that we need in our military general surgeons is a challenge. It's why we expanded the asset course into the Asset Plus course and require surgeons to take it every 3 years. It's why we've really looked at how do we maintain that? How do we build additional military-civilian partnerships at the local regional level that can allow surgeons to get additional trauma exposure on a recurring basis, so that it's not something that they're trying to remember from their training when they're in that experience. But it's challenging, right? It's with a workforce as large as ours, it's a challenging dilemma to maintain that competency all of the time.
What would you say, looking back on the deployments in Afghanistan, what was the most challenging case that you had as a surgeon? What kind of things that when you think of a case, this one comes to mind, you say, yeah, that was really a tough case?
The cases that you remember aren't always the hardest.
Right.
Sometimes they're the kids that you take care of, or the events surrounding it. If there's many casualties. The ones that stick out in my mind that really highlight, the capabilities of those facilities are the times when we would have, multiple different surgeons and teams working on one person, right? There were a handful of times where we were doing a craniectomy at the same time that we were in the chest or abdomen or both at the same time as working on the extremities to control bleeding or reperfuse them. And so that kind of teamwork and having all of the surgeons in a close-knit team come together to do that, those are the things that stick out in my mind the most from those deployments.
Yeah, I would have to agree with you. I mean, just some of the things that the team was able to do in austere locations with limited equipment and support, it just made you feel like, wow, together as a team, we're way more than a bunch of individuals.
Absolutely.
Now, let's go back to your personal story of how did you wind up in Navy medicine?
I actually wanted to go to the Naval Academy and be a line officer. And 30 years ago, your eyes had to be good enough, to be a pilot, essentially. So I found out my eyes were too bad. And so it foiled all of my plans, in high school. And so I started thinking about, how could I still be in the military, because that was important to me. And I realized that the only way that I could do that and have, the military help me with my education was to do a nursing ROTC scholarship. And so I started thinking about it. At that point, I had been thinking about maybe going to medical school. And so I decided I would, do the nursing ROTC thing and do pre-med at the same time and try to go to medical school. And that worked out. I was commissioned in the nurse corps for 2 days while I was waiting well, I was waitlisted for medical school, and the Navy, graciously allowed me to go to the Uniformed Services Universities, and I wound up in Navy medicine, and it's been a great ride.
So what are some things for our audience? What are things that keep you in uniform? I mean, you obviously made it to 06, a career. What are things that keep you here?
There's that saying, if you love what you do, you never work a day in your life.
Right.
I think that's true. I've had varied experiences in the military, and varied assignments, but I've had a very diverse career, and with each thing, I've enjoyed it, and many days, feel like I have the best job in the world. And so, I think, those opportunities, whether it's clinical practice, running simulation centers and training colleagues, or managing research programs, all of that, has been a fantastic experience.
So we've got some younger listeners on War Docs, and what advice would you give to somebody who is thinking about serving in military medicine? They're in high school, college. What kind of advice would you give them?
It's a fantastic opportunity. The military health system is going through some changes, and certainly we've seen some changes. But I still believe that our graduate medical educations are some of the best out there, and as the volume in some of our military treatment facilities has gone down, our GME programs have partnered with civilian programs, and we still have we produce fantastic doctors. The Uniformed Services University, is truly a national treasure. And so I think, I encourage people to think about it, and to think about, whether it's right for them. It's not right for everyone.
Right.
But the opportunities are endless.
We've been speaking with Captain Travis Polk on this special edition of War Docs in collaboration with OpMed TV. Thanks so much for your time and sharing your
Absolutely.
insights.
Thanks for having me.
It was really great.
Thank you for tuning in to this special episode of War Docs, made possible by a partnership with the Defense Strategies Institute's OpMed TV. To stay connected with Team War Docs, visit our website at wardocspodcast.com. Follow us on social media for updates and subscribe to our War Docs YouTube channel for more engaging content. Your support helps us continue to document the experiences and contributions of military medicine professionals as we honor the legacy and preserve the history of military medicine for the next generation.